All right, so our fifth video, prone positioning by me, Nick Riesenberg. So why prone to patients? Our bodies are not symmetrical. By prone positioning, we take weight and pressure off the lungs, allowing more air to get to the alveoli, which improves oxygenation by improving ventilation. It also improves the efficiency of the lungs by getting oxygen to the parts of the lung that get the most blood flow, which improves gas exchange. So from going sitting up to going like this, blood's going to be more evenly distributed there in the lungs. So you're going to get it to the most dependent parts, which are really going to be all of it at that point, because it should be fairly even within the lungs, which is going to improve that perfusion aspect. And then also the ventilation will be improved by, as I said, you're taking weight off of them and they're being able to lie flat. Their lungs can expand a little bit more efficiently because ARDS is a compliance issue. So that's going to help their lungs improve over time and oxygenate as well. So indications for prone positioning the patient, it's really a lot of what we just talked about. They're not ventilating well, they're not oxygenating because they can't get effective gas exchange because their compliance is shot in their lungs. So ARDS demonstrates that lack of compliance, which impinges on oxygenation, ventilation, and effective gas exchange. So when we prone them, we are relieving pressure off the workload off the lungs and the heart by letting gravity do the work of taking off weight, and so it can deliver the ventilation that we are applying and oxygenation to the most blood-dependent parts of the lungs. And doing this, it will improve oxygenation, ventilation, and gas exchange, which is the name of the game. So contraindications to proning them. So if they have an unstable spine fracture, that's going to be absolute contraindication. You cannot be moving these people around a lot. So hemodynamic instability. The rest of these are just contraindications, not an absolute. So unstable pelvic or long bone fractures. It's going to be kind of hard to wrap somebody up and move them around a lot if they have a lot of unstable broken bones. We're just going to cause more trouble than good. They have open abdominal wounds or an increased intracranial pressure. So some pre-term considerations. What should we be aware of before we start to move the patient? Because obviously anything in the healthcare, we're not going in there and just flipping them over and running out. This is a time-consuming preparation aspect that needs to be considered at all times. So confirm the patient has no absolute contraindications or contraindications prior to the prone positioning. Make sure all invasive lines are on the same side of the patient. That way you're not disconnecting, kinking tubing or anything. Ensure that all the tube feedings have been stopped prior. Confirm all invasive tests are done prior as well, because once you put them in that position, we're not flipping them over every so often or running them wherever. They need to be in this position at least 12 hours, I think. So confirm that. Conclude you have an adequate number of personnel and they can complete the procedure. That's a big part of it. You need enough people to do this properly. So the role of the RT. So priority is ensuring the airways is secure, which is about 90% of what we do really in any kind of emergent situation or dealing with any patient on mechanical ventilation, or even prior to that, we want to make sure their airway is secure, either that they can or we can provide that. So suction the patient orally and through the suction ballard. The flip should be done on the count of the RT, since the highest priority is maintaining the airway. So we need to be dictating when we are ready. They've got everyone's nurses, everyone involved has got their lines placed where they want to. We need to make sure that we do the count, because keeping that airway is most vital. If we lose a line, we lose a line. We can place another line. But if we lose an airway, we are in an emergent situation. That time is ticking. So during the flip, maintain the airway. After you do the flip, assess the airway and the ventilator. Maybe you've gotten the point that the airway is important. So prone position therapy checklist. So pre-prone checklist. Make sure you gather all your supplies and your personnel supplies, blankets, nurses, enough bodies to do that. Designate positions and roles for people. You need everybody to know, this is what I'm doing, so I'm gonna make sure I do this efficiently. That way nothing's lost in conjecture or anything like that. Acquire appropriate PPE if necessary. Prepare the lines and attachments. So in this case, like we said, moving everything to the one side of the bed. Cocoon them as tight as possible. So you're going to take blankets and roll them up, roll everything up tight, and before you move them, so you're not flailing the body around and you prevent injuries that way. So then you're going to do a horizontal move. So you're going to move them towards the end of the bed, to the side of the couple people there, and the RT is going to be at the head of the bed. So then you're going to do the lateral move. So horizontal, then horizontal, then we're going to do lateral. So we're going to turn them up one way like this. Okay, so one arm in the air, one arm in the bed. Final turn onto their stomach. And then 7, we're going to place them in the swimmer's position, which I'm going to talk about a little bit more after that. And then after that, you need a post-turn checklist, meaning check that airway, check the ventilator graphics, check their vital signs, check your lines and placements, and make sure everything worked as efficiently as possible and you're not leaving them in a bad position. And also, before I go on, checking skin integrity around things there, because that's not a normal position. You don't see as many not many patients prone. I've only, in my time, which is not long, I've only seen one patient be prone, and it was a procedure. I basically watched. I helped where I could, but it takes a lot of coordination and effort and people being on the same page and knowing their roles. So rotoprone bed. This is essentially a mechanical device that does the proning on its own a little bit, and it helps that blood flow. So you see the blue cushions around, they act as the blankets that cocoon the patient. They're already doing that for us. Instead of placing all the lines to one side of the bed, they will go to the head of the bed to reduce the risk of kink tubing or disconnection. My picture kind of cuts it off, but there's a little halo circle around the head there. All the lines will go through that. Always ensure the ET tube is secure along with the invasive lines. Again, airway protection, it's going to be a big deal. The bed will slowly rotate from left to right. That's doing that proning and moving that blood flow. And after the patient is placed in the rotoprone bed, monitor vital signs, tube placement, the ventilator, that pre-turn checklist still applies for the rotoprone bed. So how do we know this is working? How do we know this is being effective to the patient? Well, one, we can get an ABG. It can show the effectiveness by the increase in the arterial oxygenation reflected by the PaO2, and PaCO2 is not going to reflect the increase of arterial oxygenation, but we can see a decrease if they've been blowing off too much CO2, or if they've been holding on to too much. We can see that and see if we're ventilating well, because PaCO2 is going to monitor the ventilation aspect. PaO2 is going to be monitoring how well they're oxygenating. Another thing we can do is get a chest X-ray. We can assess from prior, because before they're prone, they're going to have an X-ray. So we need to look at that and say, is this working? Are we seeing compliance being increased? Or are we getting more aeration to the airways and less consolidation? So studies suggest that lying in the prone position for at least 12 hours a day significantly decreases the mortality rates in ARDS. So this is something that really grew during COVID, that people got to see the effectiveness of this. And it's a big deal in these patients that really need that help with that blood flow and that compliance issue to get them prone so their body can do a lot of that work without trying to overcome it. So preventing skin breakdown. Talked a little bit about this, but this is an important aspect of our jobs every day anyway, as being patient care oriented, but especially in this, because they're in an awkward position. You flip them over, you can't have a line underneath causing skin breakdown or swelling or edema going on. So that's one reason there's such a big checklist in checking these things out. So once position check, any uneven distribution of pressure or positioning of mechanical devices. They need to be laying flat, and pressure they don't need to be on one side more on their shoulder, causing more pressure. Everything needs to be even. Use a pressure redistribution support surface or positioning devices to offload pressure off the face and body, because their head's going to be turned. Their neck's going to be like that. So that's an awkward way to sit. You need to make sure that no part of their face or neck is absorbing the most of that pressure. It needs to be evenly distributed. Remove the devices to assess skin at least twice daily when possible, because we need to make sure none of this is getting that extra pressure or unnecessary pressure to cause any problems. At each rotation, assess the face and other body areas that may be at risk. Utilize head positioners to stabilize the head and neck. Develop a protocol and a checklist. Make sure you're going through that to make sure that there's no pressure problems or skin breakdowns going on. Educate the staff and correct use of the devices and skin breakdown prevention, because as RTs, we have many patients we see. Some may be priority, but we're not there all the time. So whoever we're working in tandem with in whatever area, probably the ICU, we need to make sure that they're on the same page as us. and that we are working on the behalf of that patient at all times, because that's what this is. That's what our job is. Bottom line is making sure that we are helping these patients, not impeding them from getting better. So make sure that you had that conversation, and us being new, they may be having that conversation with us at times. What can we do to help each other to make sure this patient is getting the best care possible? So passive movements and limb positioning. Always ensure you have enough personnel to properly turn the patient without complication. We spoke about that already. That's a big thing to consider. You need the amount of people who can do that, who are capable of doing so. When turning the patients, their arms and legs should be straight down at their side in that cocoon, wrapped up. Once the patient is properly positioned, remove the cocoon. Their arm should be placed on what's called the swimmer's position. This involves raising one arm on the same side, which the head is facing, and the other at the patient's side. So this arm up like this one down at their side, like, swimming. And the shoulder should be abducted 80 degrees and the elbow flexed 90 degrees on the raised arm.